Okay, good afternoon to all of you, and I have the pleasure of moderating this session, a wrap-up interview on transcatheter aortic valve, which has been developed in an odyssey of 25 years, and I think it's a good time today at the TCTAP to try to bring the most possible information concerning this breakthrough technology. So we have more or less 25 minutes to discuss about transcatheter aortic valve implantation, the state of the heart, and the future developments. So the issues in brief are summarized here. What do we know about this technology? Do we have any evidence-based results? And where are we with the recommendation and guidelines? Can we think about moving to subsets of patients like intermediate risk patients? What do we know about very interesting indications, valve-in-valve for failed bioprosthesis? What are the current complications and the way to prevent and treat them? And what could we say about the advanced technologies and the new devices? So the first slide is a very important slide showing the evidence-based results of the partner trial. The first valve was implanted 12 years ago, and this evidence-based study was published 4 years ago. And this slide was a very important milestone, showing that in patients with critical aortic stenosis and not able to be operated on, unfortunately, they die if we don't do anything, and with TAVI we can save about 25% of the patients. Second part of this partner evidence-based trial in the United States was about the so-called high-risk patients, where clearly the results of TAVI and AVR were more or less similar at 3 years. So these results were published in 4 major issues of the New England Journal of Medicine. Very recently, and this was a few weeks ago, we had the results of a pivotal trial with the Medtronic core valve in the United States, showing that even in high-risk patients, this TAVI procedure could benefit a little better than surgical valve replacement. And this was the first time that this advantage of TAVI over surgical valve replacement was shown with a percutaneous valve. We had also a few weeks ago published at the ACC meeting this randomized comparison of the two devices that have been currently used in the world, the Edwards balloon expandable valve and the Medtronic core valve, showing, as you can see on the slide, some advantages maybe of the Edwards valve over the core valve, which is self-expanding against the balloon expandable Edwards, with a little more device success, mainly related to the number of valve implanted, the aortic regurgitation, and the rehospitalization for heart failure, and the number of new permanent pacemakers. Recently, in 2012 in Europe and in 2014 in the United States, came up the guidelines on the management of valvular heart disease, and it's clear that the recommendations are to use this new technology in patients who are not operable, so-called class 1, not suitable for AVR, and in high-risk operable patients as an alternative to surgery, as determined by the heart team and case-based decision. So these are two very important aspects of these indications for the procedure. Today we can give these pictures concerning the indications for TAVI, and we have on the right patients who are too sick to have this procedure done because it won't be useful for the patients. We have the patients at very high risk for surgery, so-called inoperable patients, where TAVI has good indications. Patients at high risk for surgery, where we can hesitate and we can discuss between TAVI and surgical valve replacement according to the opinion of the heart team. And in the middle we have this huge group of intermediate risk patients, and this is today a matter of discussions. On the left we have the low risk patients who are still surgical candidates. So we have some indications that in low intermediate risk patients, TAVI has an interest. We have this study from Weser, published in the European Heart Journal in 2013, showing that there is a significant difference in the survival of patients at high risk and intermediate risk. So this would push the people to start thinking about including the indications to this population. Finally, we have this valve-in-valve procedure, which is extremely important for failed bioprosthesis. And again, it has been shown that implanting a valve-in-valve for degenerated bioprosthesis could save a number of lives, and especially in those patients who are not at extreme high risk. So the current limitations of TAVI are written here: paravalvular aortic regurgitation, stroke, new permanent pacemaker, and vascular complications. Finally, we have some new valve designs that are already tried in Europe, accepted in Europe, or on the way to be accepted in Europe. The Sapien 3, which is a new model for the Edwards valve, and the Centra, which is a self-expandable Edwards valve, which interest is mainly to decrease the complication rate, the vascular complication rate, because of the use of smaller introducer, and also to have a very proven effect on the aortic regurgitation. And we have on the core valve, with a new core valve Evolute, which offer better fitting with the annulus structures. And many other new devices are already validated in Europe, and many others are coming, and it's a little too early to conclude about the benefit of these devices in comparison to the so-called first generation devices, but this is extremely promising. So I think we can start the discussions, coming back on more or less on the slides. I would like to ask the opinion of my colleagues concerning the trend towards lower to intermediate risk patients, this big move that is really expected. And as you may have heard, we have today randomized trials with the core valve and the Edwards valve, and the results of this randomized trial are really expected. So do you have any feeling about what could be the results of these trials? What are you expecting yourself? Marty?
Well, it's interesting because I think, in effect, we've not already done the studies, but we've already evolved to the point where, in most environments, the moderate intermediate risk patient is offered transcatheter valve therapy. There are some exceptions. I think if you have a heavily calcified bicuspid valve, or you have other situations where clearly surgery may be an advantage, you might not offer it. But under many circumstances, it seems that we've already gone to intermediate risk patients. And the indication is that when you look at the more modern studies, and I consider that the U.S. core valve pivotal clinical trial is a more modern study. It began 4 years after PARTNER. And the thinking had already evolved. And if you look at most of the risk parameters, it was still a high-risk group, but it was high-risk trending towards intermediate risk. And then if you look at the TVT registry, which is the commercial approval registry in the U.S., the median STS score is only 7, whereas PARTNER was 11.8. And 60% of the patients had STS scores that were 6 or lower. So when you see these things, you can begin to understand that the field has already moved. And it's my opinion that when we finally have the results from these 2 large randomized trials, PARTNER and TAVI, that will probably validate what most of the clinicians already know, that in moderate risk patients, that this therapy is at least as good as surgery.
Eberhard, concerning the core valve and this recent pivotal trial with excellent results, I noticed that finally the risk score was relatively low, so you already treated intermediate case patients, don't you think so? And
yeah, so I share this, and I couldn't agree more with what Marty just said about the trend and about the perception of risk in the medical community. But I think what we have to also deal with is what really is intermediate risk. This is a definition problem. Initially, we were following the scores, knowing that the most important agency in the world, the FDA, insisted on the scores. learning from the scores, knowing also about their inability to truly define risk. In our sense, I think CoreValve showed that depending on judgment from physicians, both surgeons and interventional cardiologists define risk a little bit differently. That is not necessarily reflected by the score, as we've seen in the CoreValve study. By scoring, it's already in the intermediate position. So the definition part is one thing, and I think what Marty said, I totally agree that every study that's out, every serious study that's coming out, supports this trend that intermediate risk is something that the patient will definitely profit.
And sorry, Jan, do you in Australia do you observe the trend to include more and more lower risk patients?
Yeah, we do, and I think the way in practice we actually make decisions about patients for transcatheter valves really it's at three levels. There's the philosophical level, the clinical level, and then the technical level. And the philosophical level is this an appropriate thing to do for this person, for this family, for this healthcare system? The second level, of course, is the clinical decision. Are the symptoms really the cause of or is the problem the cause of the symptoms? And will you be treating it? And the third, the technical. And I think what we've seen is a move to people making more philosophical decisions about the value of the therapy and in whom you're going to see the greatest benefit. And we've seen a lot of data come out as to utile versus futile, or if you like, functional versus futile. And
I'm sorry, but concerning the widening the indications to intermediate risk patients, are you, each of you, concerned about the unknown durability of the devices? Because this is important if we want to move to the younger patients.
Well, I think that there's two aspects of this. When we're talking about intermediate severity, or suggesting that the patients in the recent CoreValve trial were lower risk, they were still average age of the 83 or 84 years, and yes, their STS score was 7, or a little over 7, but they had a number of other functional markers to suggest that they were high-risk patients. So I think if we broadened the spectrum to taking patients who were 65 or 70 with minimal risk, I think we'd all be worried about the long-term durability of the valves.
Well, the good news, I can tell you, is in my center, we have now a patient crossing 8 years. So this is probably the world champion on durability, yes. And he was implanted with the so-called Cribier Edwards, so the very first generation of device. So this is good news, without any valve deterioration.
I think the patient age issue is an important issue because we don't know with certainty what the durability is. But I must say, as each year passes, we're feeling more and more confident that durability is not going to be so much of an issue, that these are the same bioprosthetic materials that surgeons used, and that there's no evidence of early structural valve deterioration. So I think most of us would predict that you're going to have close to surgical durability. But it's still wise, even if you drift down in the risk profile, to try to probably treat older patients. I think if you start treating patients in their early 70s, I think with unknown durability, then you could be legitimately criticized.
There has been some indirect changes in surgical habits as a consequence of this, because I think we've all seen the surgeons moving to bioprosthetic rather than mechanical valves at an earlier age cutoff, with the assumption that the patient might have a transcatheter valve if that valve fails in later life. So I think those things are all indicating that even the broader community, surgeons and physicians, are seeing this as an appropriate therapy for more than just the extreme or high-risk patients.
I'm sorry, but we have 5 minutes to go and cover the complications of the procedure that we can observe today. So we have several complications which are more or less dangerous for the patients and life-threatening, like aortic regurgitation. You have seen the results. Aortic regurgitation. We have to do something against that. We have also the vascular complications and so on. And so I have the feeling that things are improving with the advanced technologies. And today, Marty did a fantastic presentation on a new device, and also Eberhard. And so how do you see the future what could be the effect of this new procedure, new technologies, new valves, new delivery system on the prevention of these complications?
When I talk about complications, or I would like to think about something that Marty brought up and is still so wonderfully described in his three-color scheme of a traffic light, the red, the yellow, and the green, which is still absolutely valid. He considered something red, which is probably very difficult to overcome. So, for example, the pacemaker situations in the self-expanding valves, but there are others that might actually be resolved over time, which he put in yellow, and then the green is something that's okay. That's still very, very valid today, and I believe those traffic lights, those red, yellow, and greens are still very relevant in terms of complications. Overall, I believe it will get better. Some things we won't change. As I said, the pacemaker rate will probably always be higher than in Edwards as a balloon expandable valve. But we're learning here, and we don't quite understand the total impact of each individual valve with that complication, but I think there will be a difference. The other ones, I believe, will get better, particularly vascular complications as we learn more, as the sizes are going down, and of course PVL with the new designs.
Anything to add on this
I did notice, though, in the CHOICE study, we saw that the 30-day mortality was very low. The rates of aortic regurgitation with both valves were low, the stroke rates were low, but the vascular complications were still significant. So there's obviously room to improve the vascular access. I think we're doing a wonderful job with aortic regurgitation. I think we continue to see that improved measuring and deployment techniques and other technical aspects of the new valves are helping, but vascular complications are not changing, in my mind, at the rate that some of the other complications are.
And Marty, do you want to add something on this?
Yeah, I think you're right that the complications are improving. I think with time, I think it's better case selection, better procedural technique, better devices. Mm-hmm. I think we've just gotten better, and it's our awareness and our self-criticism that we have to do better. So I think that in a modern, high-quality center, the vascular complication, the important one, should be less than 5%, and even when you get them, you should be able to correct them without endangering the patient. The stroke rates have fallen to 2 to 3%, which is extraordinary. I think very, very important, because we weren't sure that we could overcome that. The paravalvular leak with the new devices, new techniques is going away. It's going to be like a surgical valve. Yep. Pacemakers, I think, yes, that's a logistic issue, but I think it varies from device to device, and there are some unusual complications, but are still very important, because when they occur, they can be devastating, like coronary obstruction or annular rupture. So these are still things that we have to be aware of, but the overall complication profile has improved sufficiently where we can say, with surgery we have complications too, and we can say that they may be slightly different. The complication profile may be different, but we think that we are quite competitive.
Among this perspective, first of all, there is the valve-in-valve. I am very much interested by that and the treatment of degenerative bioprosthesis. Do you think personally that we should ask for some specific devices for that, specific valves, or can we be happy with what we have in hands today?
Personally?
Which one? Valve-in-valve?
Valve-in-valve.
Valve-in-valve, as shown today, is one of the, for me, it's one of the most gratifying indications for this technology, because patients are really sick. They are, if nothing will happen to their valve, they're going to be having a downhill course, and it's a redo surgery. And overall, even sick patients are really doing very, very well with a relatively straightforward procedure, both by Edwards, by the SAPIEN valve, and by the core valve. So I think this is a very, very interesting, important indication for something that has been very difficult to deal with in the past. As far as aortic regurgitation, mitral valve is concerned, aortic regurgitation, pure aortic regurgitation, I think we need modifications of devices, a different approach of devices, or completely new devices. But it's a very interesting field.
And what about the new indications, like, for example, aortic regurgitation, pure aortic regurgitation? You have shown, Marty, a new device from Edwards, which looks like more or less okay for that? No? So do you have any personal opinion concerning this device?
Well, it's a little complicated because it's 2 steps, and it's either 2 access points, either TFTF or TFTA. But I think it's a provocative way to approach this. We're looking at the Jenna valve, which is kind of interesting because it's almost designed for pure AR because it clips to the leaflets. And I think that's another approach to it. And I think there'll be other self-expanding and different devices that can manage pure AR. But I believe that if we have the right device to the anatomy, because the roots are larger, the valves are larger, they're not diseased, you don't have calcium, so you have to develop special devices. But when we do that, and if the valves are durable, I can't see a reason why we would be operating on pure aortic regurgitation either. I think that the transcatheter valves will be the solution in the future.
I agree. The other one, obviously, is direct flow. That's one that's immediately in front of us that might actually be a successful solution to pure AI. I suppose the AI associated with the bicuspid valve presents a more complex challenge because of the associated aortopathy and whether that needs to be treated in isolation or whether you need to treat the entire problem. I think that poses a problem for us, really, that we don't have a great solution for bicuspid valve disease because of its known associations.
And may I ask questions about the other indications like the mitral valve, which is a new field, the mitral valve replacement? How do you see the future of that?
I think 2014, at least in my rosy prophecy, maybe, I think we will see dramatic change. Well, not dramatic, but we will see a change in the whole pattern of treating mitral insufficiency this year, because we have successfully seen 2 valves already implanted, and I think this is going to be the year. 2014 will be the year where mitral valve insufficiency will be attacked, if I may say, by percutaneous techniques, transapical and possibly transvenous approaches.
Well, which is interesting, when we are discussing with companies, the answer is we have more mitral regurgitation than aortic stenosis. So mitral regurgitation is a huge market. I don't like to use the word of market for patients, but this is a word that they use. And do you really think that this mitral valve should be as successful as the aortic valve as a way to replace it? Do you think that the market is as good as they think?
It's a big market, but it's the mitral valve is a much more sophisticated structure than the aortic valve. The aortic valve blows open easily during systole. The mitral valve has to be patent and strong during systole. It's a very different structure. I think I'm not sure I share your rosy prophecy. I think the mitral valve is a much bigger opponent than the aortic valve because of its complexity and the nature of the disease process, annular, leaflet, cord, papillary muscle. It's a much more complex structure with multifactorial causes. So I take a breath in before I'd say it was a rosy prophecy that we'll see the truth. I think functional mitral regurgitation, there's some very, very good solutions.
But I do feel that Eberhard is correct in the sense that we have been stymied by how to manage mitral valve disease using transcatheter techniques. And for a decade now, we've been floundering. And now I think we have overcome the inertia, and we've already demonstrated that you can replace the mitral valve, and you can do it successfully. And there are about a dozen companies that are going to attempt to do that over the next year or two. And I think there'll be a group of patients that would certainly benefit from that, recognizing that this is a multifactorial disease. As you say, it's not just the valve and the valve structure, but it's also the myocardium. So there's a lot of complexity of how to manage mitral regurgitation. It's not as straightforward as aortic stenosis, which is the ideal target.
It is. It's
mitral regurgitation is much more sophisticated, much more heavily nuanced. So how we manage these patients will be difficult. But I do think there'll be a place for transcatheter mitral valve replacement, and we're just beginning to discover where that will fit in.
My friend, we have to move to conclusion, and we have 1 minute. So I would like to share my enthusiasm with you concerning the progress that we have made in the field of transcatheter aortic valve implantation. You know, I had the privilege of working on that for many years. Today, this is turning like a stunt-like procedure. I would like just to focus on that, you know, because it's a routine technique. For example, in my department, we have been really pushing towards the local anesthesia and making it extremely simple. And what I can observe today, it's a 40 minutes procedure. Local anesthesia, the patient is discharged at day one. You know, this is the way it works, you know, so this is absolutely unbelievable. Do you share the same enthusiasm?
It is absolutely amazing. It's staggering.
Okay, thank you very much for being here. Thank you very much.
Thank you.